Afternoon, everyone. My name's Mark Henderson and I'm the Chief Executive Officer of Myeloma Australia, and I wish to welcome you to our seminar series as part of National Myeloma Month. Before we begin, I'd like to acknowledge the traditional custodians of the lands on which we are gathered today. I want to pay my respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people joining us today. National Myeloma Month is a time to shine a light on myeloma, an often overlooked and misunderstood blood cancer, as I'm sure you'd appreciate. With survival rates that lag behind many other cancers and the growing burden on patients, families and the healthcare system, awareness and action has never been more important. In 2025, we are focused on driving real change. Our goals include increasing access to specialist myeloma nurses, improving support services for patients in regional and rural areas, and advocating for improved treatments and healthcare policies. Through greater awareness, research, and support, we are committed to making a tangible difference in the lives of people living with myeloma. Today, we'll hear from a range of experts who are at the forefront of research, treatment, and patient support. Whether you're a patient, a carer, a healthcare professional, or simply an advocate for better outcomes, your presence here matters. Thank you for being part of this conversation. Let's get started.
Foley, and I'm one of the specialist myeloma nurses with Myeloma Australia, based in New South Wales. I'm joined today by my co-host and fellow nurse, Shani Dickinson from WA. March is International Myeloma Month, and in Australia during this month, we aim to raise awareness of myeloma and provide access to experts in the field through our national online live seminars and our local My Greatest Walk community events. The 2025 live interactive seminar series takes place over 2 days, today and again this Thursday, the 20th. Our theme this year, My Myeloma Matters, a focus on you, not just your disease, aims to take a deeper look at the future of targeted treatment and individualised supportive care. We have some really interesting presentations coming up for you. Today's seminar runs for approximately 2.5 hours with a short 5-minute break scheduled around 1:15 p.m. Australian Eastern Daylight Savings Time. A reminder that the session will be recorded and available for playback on our website. Working behind the scenes today is our colleague Narelle Smith from WA. Narelle will be monitoring your questions, which you can submit today via the Q&A box if you scroll down the page, or via the live chat box, which is available by tapping the 3 dots in the top right corner of your screen. We will do our best to respond to your questions, but please include your email so that we can respond that way later if required. You can also email any unanswered questions directly via email to nurses@myeloma.org.au. We'd love to know what you think about today's session. Your feedback is really appreciated so that we can tailor future events to meet your needs. You'll find an evaluation link at the bottom of this webpage. Should only take about 2 minutes to complete. With the housekeeping out of the way, it's now my absolute pleasure to welcome our first presenter. Dr. Christian Bryant currently works as a haematology staff specialist at the Institute of Haematology at the RPA Hospital, with a clinical focus on multiple myeloma and stem cell transplantation. Christian does research in immunology and haematology. He's currently researching T-cell biology, investigating novel approaches to use minimal residual disease testing, and setting up clinical trials for multiple myeloma patients under the ALLG. Dr. Bryant is a member of Myeloma Australia's Medical and Scientific Advisory Group, and he's here today to talk to us about My Myeloma individualised treatment targets. Thank you, Dr. Bryant.
Thanks very much, Kath. Thanks for that kind introduction. It's a real pleasure to be speaking here today and have the opportunity to talk to you about some of the things that I think are important for patients and families and caregivers to know about myeloma. I have tried to make this applicable to individuals. I'm not going to throw thousands of clinical trials at you, because I think doctors do that too much, and it makes us feel good because there's lots of data to present. But I often worry that my talks in the past haven't been palatable and haven't been delivered information that's useful to individuals, to patients and their families. So I've purposefully tried to have less data and more kind of synthesized content in this. And maybe at the end you can tell me whether I've been successful. But this is the overview of this talk. I think the really important things that I wanted to discuss are how we approach myeloma from a clinical trial perspective and from a risk profile. What is risk? You know, when we're talking about a disease that we can't cure at the moment, it's all high risk, right? There's no good risk myeloma. It's a bad disease. We know that. So if it's all very difficult to treat, how do we split patients up into standard risk and high risk, and what does that mean, and what can that help you as a patient or you as a family member? How can that help you make decisions? And I'd like to try and address that. I wanted to go through what state-of-the-art tests we have in Australia, because actually we've got really great diagnostic tests for myeloma that are all fully funded. And I think it's good for patients to be aware of what's available, so you can be motivated to know that information to make sure you've had the right things done. How can these new tests be used? Are there ways that they can help you to make decisions? And I'm going to be talking about a special type of test we call MRD, or minimal residual disease, which is a personal interest of mine. And I hope to explain that so that you could maybe talk to your doctor and say, oh, can you run an MRD test on me if it was going to help you make a decision? And then I think it's really important for us to acknowledge that myeloma is actually not one disease, it's many. And it means that different patients will have very different experiences, and different treatments will have different efficacies, and each patient's treatment decision needs to be highly individualized. I think that's important for doctors to know, but it's really important for patients to know, so that you don't unfairly compare yourself to others and think that you're getting the wrong treatment or different treatment to other people, because it's likely that that treatment is different for very good reasons, because it's tailored to you. And then briefly at the end, I'm going to talk about some of these targeted therapies, time providing, that I think are going to be the future of how we target treatments to myeloma patients. So my clicker doesn't work. Yes, it does. So I think the first thing to say is, what does risk mean in myeloma? And I think this always makes me feel really uncomfortable, because when we're talking about risk, we're talking about people as groups. And you might say, if there's 1,000 myeloma patients, 30% of them are predicted to have this outcome, 70% this outcome. And that's horrible, because you're not a number, you're a person. So our patients with myeloma are not numbers, they're people. These are tools to help you make choices, but you should never be seen as a number. And I think it's just really important to say that we deal with these numbers because we're trying to make good choices about the future, but really they're just tools for us to make choices. And your choice and your independent therapy for you will not be the same as all other people who've got high risk or standard risk myeloma. But I think the importance of risk is that when we identify patients who've got a high risk, should they have different treatment to people who've got standard risk? Are the risk benefit of different treatments different in those two groups of people, and which group might you lie in? And then the other big question I wanted to address is, if you have high risk myeloma, should you have more therapy and try and get to a point of deeper disease control? And that's a big thing that we talk about a lot in trials at the moment, and there is some data that might help us. So this is the international staging system. This is the way we have been staging myeloma for the last 10 years. It uses some simple measurements, like the amount of good protein in your blood, your albumin, this thing called beta-2 microglobulin, which really is kind of a measure of how much myeloma there is in the body. And it uses this other marker called lactate dehydrogenase, which is a marker of myeloma that's growing really quickly. So it's normal in most patients with myeloma, but when it's high, it shows growing myeloma, which we think is higher risk. And then these genetics. Now, genetics in myeloma is constantly changing and getting better, but when this was designed 10 years ago, these 3 bad genetic features were thought to be important. And using this RISS, or Revised International Staging System, we can put myeloma patients in one of 3 groups. Now, they're called stages. If you go back one, if we can go back to that last slide. Thank you. But actually, stage is actually a really dumb word in myeloma. We think about stage with breast cancer and lung cancer and colon cancer when it moves outside of one organ into other organs. And that's where you get, stage 1 disease might be a localized tumor. Stage 3 disease is when the tumor has spread more widely. In myeloma, that doesn't really operate, because in most patients with myeloma, when they're diagnosed, they've already got myeloma in a lot of their bone marrow. And then I guess it's possible for it to spread beyond the bone marrow, but that's only the case in a minority of patients. So actually the stage 1, 2, and 3 is sometimes not very helpful. And when my patients ask me, what stage am I wonder whether it should not be called stage. It could be it's called something else, and it's really risk group. And if you have a look across at that diagram on the right, which is actually, it's called a Kaplan-Meier plot, what it shows is for each line, if you draw a line up from time in months, and then to the left to the overall likelihood of being alive, which is very confronting data, it shows that in the risk group 3, at 60 months, only about 40% of patients are alive, which is terrible. Now, this is old data. This is data from 10 years ago. This has changed now. So the outcome of patients in that 3 group is now much better than that. But it shows that in patients in risk group 3, they have a lower chance of being alive than patients in risk group 1. So it clearly is important, and it's able to predict how patients may fare, not with 100% accuracy, but that suggests trends. And the way that we now use this risk group 1, 2, and 3 is if somebody's in risk group 3, we are worried that their outcome with standard treatment is not going to be good enough. And in our practice, we would worry that patient you may need to discuss availability of clinical trials or new treatments that might make that outcome in risk group 3 get better, because we would like all those lines to be a flat line that goes straight across the top. If that was a flat line, that would show that no patients were passing away from myeloma, and we'd managed to make even the patients in risk group 3 have good outcomes. Until there are 3 flat lines there, it's not good enough. So we've got a long way to go. Now, if we move on to the next slide, this is from a talk I give to the junior doctors nationally about myeloma genetic techniques. And it can look a bit overwhelming, but I'll try and explain to you what this data means. So we now use 3 main techniques to assess the genetics of the bad cancer cells in myeloma. And we do that because we know that the genetics is probably the most powerful predictor of how myeloma is going to respond to treatment, how long it's going to stay, if we go back again, how long it's going to stay in remission, and whether it's worth being exposed to more drugs or less drugs, and try and help with some of these decisions. On the top left, you can see conventional cytogenetics. Now, that is a test done by myeloma cells being removed from the bone marrow at a biopsy. The myeloma cells are then sent away to a laboratory where they grow in a test tube and get frozen at the point where the chromosomes are separating out as the cell divides. At that point, a very highly trained scientist can actually look with a microscope down at the chromosomes, and they're so good at their jobs that they can see that that's chromosome 1 and that's chromosome 3. And for example, in this example that you can see before us is one of the commonest patterns for chromosomes to be abnormal in myeloma, and it's called hyperdiploidy. And it means there are extra copies of chromosomes, and they are typically extra copies of odd-numbered chromosomes. No one knows why that is the case. It's just a strange convenience of a fact that makes it easy to remember them. But this pattern of hyperdiploidy without other genetic damages is actually one of the better genetic changes that can happen in myeloma, and it puts patients in a standard risk group. For example, you might see bits broken off some of these chromosomes or additional bits, and some of those features are bad and some of those features are better. This is the oldest technique that we've used to assess genetics in myeloma, and it usually doesn't work. It works in about 10% of cases, because most of the time when you take myeloma out of the body and you try and get it to grow, it doesn't. One of the great strangenesses about myeloma is very hard to kill in the body, but as soon as you take it out, it's very difficult to keep it alive, in fact. So conventional genetics has been replaced now by the bottom two tests that you can see there. One of them is called a DNA array, where we purify the myeloma cells from the bone marrow and look at their DNA against a comparison background. And the other is FISH. And FISH are these little probes, fluorescein in situ hybridization, which detect very specific genetic changes which we know to be of high risk or of clinical significance. And now, if you had a diagnostic bone marrow biopsy for myeloma, you would most likely have those two bottom tests done. You're only allowed to do them once. You're not allowed to do them again and again, or you have to pay for them, and they cost hundreds of dollars. But most patients in Australia get a DNA array and a FISH, and that's very good state-of-the-art testing, actually. It can pick up most important features. This is very new. This is not yet published, but this is just presented by Jill Correa at the International Myeloma Society meeting last year and is about to be published in the Journal of Clinical Oncology. This is the new high-risk features for myeloma. Now, what this means is if patients have these genetic changes, we're very worried that standard treatment is not going to be good enough. That's the decision that's helping us make, so that we can think about what could be done to make patients who've got these genetic features do better, and focus effort on these poor patients who have these high-risk changes. And you can see there are things that we've known about before, like deletion 17p. There's now this thing called T53 mutation, which you need to do special testing called next generation sequencing to pick up. Hasn't been there before. 2 lost copies of chromosome 1p, and then all of the other high-risk features which we previously put patients in the high-risk group have been changed. So having 1416 translocation or 1420 used to be high-risk features. They're now only high-risk if they're combined with other things. And that's because over the last 10 years, our treatments have got better, and patients who have just those translocations are actually not doing worse than other patients because of the change and improvement in therapy. And it means that as the therapies get better, you have to, if you can go back again, you have to reassess whether things are really high risk or make patients have a worse outcome. So now you need to have extra copies of 1q or lost 1p if you're going to have one of those translocations and have a high risk phenotype. If we can go to the next slide then. Yeah. And so, as I've said before, this concept of risk is important if it informs choices. And they need to be clinically relevant choices for patients. And I know there are patients listening today. This science is meant to help you and your doctors to make good choices about interventions which make you sick. You know, let's be honest. Many of the treatments that we use for myeloma aren't easy, and they're not pleasant, and they make you sick. So they need to be worth it, and they need to be worth it as much as possible as we can figure out for an individual. So on the left is a Kaplan-Meier plot. Once again, it shows the proportion of people over time who remain in remission, right? So right at the beginning and the far left of this graph, everybody's in remission. So the probability of people being in remission is 1, it's 100%. Over time, as patients unfortunately relapse after the treatment, these lines drop, and you can see that out at 8 years, there's about 25% of patients in the blue line that remain in remission, and it's about 45% in the red line. Now, the blue line and the red line are the same chemotherapy treatment, and that's what we use in Australia now. So lenalidomide, Velcade, or bortezomib and dexamethasone, which we used to call RVD, Revlimid, Velcade and Dex. And the difference between these two lines is one group of patients had a transplant and one did not. And this is looking in the high-risk patients from this big study called Determination, and showing that there's a big difference in length of remission in the patients with high-risk myeloma had a transplant. Actually, a bigger benefit for the high-risk patients than there was in the standard risk genetic and risk patients. And this shows that if you've got high-risk genetics in myeloma and you have lenalidomide, bortezomib, and dex, you get a big benefit from having a transplant. So when you're thinking about weighing up whether a transplant's worth it or not, you should strongly think about the benefit of a transplant. In fact, the average or median remission without a transplant was 17 months, and with a transplant, it was 55 months. So it's gone up more than 3 times. So that's one way of using risk to help us make decisions about whether something's worth it. And in this case, it's a melphalan autologous stem cell transplant. It's pretty heavy and makes you quite sick. On the right, this is from another big study which was published a couple of years ago now called the Master Study. This study was an everything but the kitchen sink study, right? So they asked a different question. They said, let's give all our patients every drug that we can justify giving together, and then stop if there's no myeloma left. And let's see if that works as well as continuing drugs on and on and on. So it's daratumumab, carfilzomib, lenalidomide, and dexamethasone, all 4 drugs, very strong. And it's given until patients have no detectable myeloma in their bone marrow with a very sensitive test. And what it shows is that worked quite well if you had no, in the red line, high-risk genetic changes. That's what that red line is. They're patients who have none of those bad genetic features. But in patients who had 2 or more high-risk genetic changes, they didn't stay in remission after stopping therapy. And it suggests a really important kind of fundamental point, and something I wanted to get across today, is if patients have higher risk, higher genetic risk, it's even more important that they stay on therapy and that they stay on as much therapy as you can tolerate, really. As patients have lower risk, particularly in this master study, if they don't have those high-risk genetic changes, it's more justifiable for them to have some treatment and get into remission and then stop. And that concept of trying to maintain responses if you've got higher risk and maybe being a bit more prepared to stop therapy if it's appropriate, if you've got lower risk, is I think, emerging as a fundamental decision-making tool for us. Next slide, please. So I'll just summarise that last section of the talk then. So what can we do to improve outcomes if myeloma is high risk? Well, first thing is risk prediction isn't accurate. It's accurate if you take 1,000 people, but it's not accurate in one person. So if you are listening and you're one person, do not despair. And I think more important than what your risk is how you're coping and how your myeloma is responding, because there'll be people in that high-risk group who will do well. And that's very well known. And I've got patients in that situation in my clinic. So don't despair. Look at your own story and your own features and how you're going first. But I think there are still some principles. And I think if you've got higher risk myeloma, you want to try and maximize your exposure to multiple effective drugs. There's a very proven in both standard risk and high risk myeloma maintenance therapy is very well proven. Okay. Can we go back a slide? We can hear some other people. Someone want to mute their microphone? Maximize exposure to multiple effective drugs, and maintenance therapy has been shown to be useful in all myeloma, but I'm even more inclined to suggest ongoing maintenance therapy in higher risk myeloma. And of course, I think high-risk myeloma patients should be thinking about clinical trials and thinking about getting access to therapies which will change their outcome earlier in their therapy. So look, this is the old International Myeloma Working Group response criteria. It's what we still use in clinical trials. I'm sure there are patients online who'll be familiar with some of these terms. It's actually pretty complicated. It's difficult, I think, and not terribly accessible for patients. But in short, what the IMWG did quite a few years ago now, more than 10 years, is they tried to use paraprotein and light chain responses in the blood. So simple blood tests everybody has access to, and in some cases urine and bone marrow testing, to grade responses. Because we've known for some time that in most situations, or in the majority of situations, maybe fairer, getting a deeper response is better. But that's not always the case. And these 4 major response criteria are stringent complete response, which means normal bone marrow and disappearance of paraprotein and normalization of light chain in the blood. CR is complete response. That means there's no paraprotein, no abnormalities in the urine, good response of any soft tissue masses, and less than 5% plasma cells in the bone marrow. And a VGPR, which is often a very good depth of response to get, means you can measure, but you can detect but not measure the paraprotein, and there'd been a big change but not a complete change in light chains. And then a partial response is a 50% reduction in the paraprotein, and it's a bit more complicated for light chains. So going in reverse, it's partial response 50%, VGPR 90%, CR complete disappearance, stringent CR, complete disappearance, and normal marrow. Now, these are the old criteria. On the next slide is the concept of, can we get deeper than this? And yes, we can. And we can do this with paraprotein, with MRD testing. And so this picture is an iceberg, because it says that really getting to a CR is just really the tip of the iceberg. Actually, you can detect myeloma using very sensitive tests down way, way, way deeper. And for example, the test that we run here at RPA, and samples can be sent to us, is called next generation flow cytometry. And that can detect down to about 1 in 500,000 cells being abnormal. So 1 in 10 to the minus 5 cells being abnormal. And we're designing a new test that's going to get deeper than that even. This is all data from myeloma.org that you can look up. This is the test that we run. This is a test called flow cytometry. What we do is we take bone marrow, we label that bone marrow with antibodies against markers we know are on myeloma and markers that are on non-myeloma cells. And we then run as many cells as we can, and we try to run 20 million through this very sensitive machine called a flow cytometer. And we look for abnormal cells. And we can call this if we see up to 20 abnormal cells. In this example in front of you, you can see the red cells are abnormal because they shouldn't have that CD56 marker on them in the light blue, and they should have CD19 on them. So this allows us to detect abnormal cells down to very, very low levels. In this case, there's 0.0036% abnormal cells. It actually looks like quite a lot, doesn't it? But actually it's a very low number. So these very sensitive tests allows us to tell our patients whether they've reached this state of what we've called MRD negativity, or no detectable myeloma with a sensitive test. And that has lots of implications. So for example, we know that patients who get to MRD negativity after a transplant are likely to have a longer remission. We know that patients who remain MRD negative maybe a year after maintenance therapy after transplant have a lower risk of relapsing. And this doesn't tell us what to do yet, but it's just another bit of information which in some situations can help patients to make their best choice. I think it's really important to say that it doesn't yet tell us what to do, and you should still make good decisions based on your disease as a whole. But it can be a tool, if interpreted correctly, can help and empower patients to know what's going on beneath the surface at the bottom of that iceberg. Next slide. So this might be then one question that we could ask. If I'm in a high risk group, like that stage 3 or risk group 3, and I get to no detectable myeloma in the bone marrow in A on the left, do I do better? And the answer is yes. So this is a trial where patients are given basically what we give a transplant eligible patient under the age of 70 in Australia now. They've had lenalidomide, bortezomib and dexamethasone 4 times, and then a transplant, some consolidation and lenalidomide maintenance. And on the left in A, you can see the outcome or the likelihood of staying in remission in the patients who have no detectable myeloma using a sensitive MRD technique after their transplant. And what it shows is that the risk group 3 patients do the same as the risk group 1 patients. And that means that if you get to this MRD negative state, you're likely to do the same regardless of your risk, which is actually really reassuring and justifies being exposed to more intensive therapies like a transplant, for example, particularly if you're in that risk group 3 group. Whereas in B, unfortunately, in the patients who did not manage to get rid of that MRD after their transplant, there's a big difference in outcome in the risk group 3 patients and the risk group 1. And if you look in the green, in the risk group 3, at 2 years, less than half of those patients remain in remission. So despite having all those drugs, despite having a transplant, those patients who don't get to MRD negativity have had a worse outcome. And that's actually a big problem and something that we need to address. And there are numerous trials around the world that have been recently published and ongoing to try and address that problem of what you do if a patient continues to have minimal residual disease after their transplant. Next slide. Yeah. So, but then what about this? What about asking a different question? And I'll spend some time talking about this because it makes your brain hurt until it's been explained. One question might be, well, if I've had a transplant and I've had all of these drugs and I get to very deep state of disease response where you can't detect any myeloma in my bone marrow using an MRD test, do I really have to have lenalidomide maintenance therapy? I mean, we use lenalidomide maintenance therapy in almost all patients at the moment, and that's because it's shown unequivocally to broaden, to lengthen remission length by about double. And one of the questions that's asked, particularly if patients are having side effects from lenalidomide like diarrhea or low blood counts, is, well, if I'm MRD negative, can I stop the lenalidomide? And what this data shows in the 2 red lines, so the hard red line is patients who have no detectable myeloma but stay on lenalidomide, and the dashed red line is patients who are MRD negative and don't get lenalidomide, is you do better if you're MRD negative and you have lenalidomide. In fact, that's the group that has the longest remissions. So just because you reach MRD negative doesn't mean, unfortunately, you can stop maintenance therapy at the moment. What this line also shows that if patients continue to have detectable myeloma in their bone marrow down at these very low percentages, like 0.0004%, those patients with those tiny bits of detectable myeloma definitely have a better remission length with lenalidomide. And that is the solid blue line, which has a, maybe at 4 years, there's 40, 50% of people who are in remission, as opposed to the dashed blue line, where about 10% of people are in remission after 4 years. So what we can say from this is, yes, it's nice to know what MRD is doing. It's nice to know how deep your response is, but it doesn't yet mean that you can stop lenalidomide maintenance. It doesn't actually change your treatment. It might be part of the information you could use if you were really worried about drugs like lenalidomide, but we can't yet say you'd be better off stopping lenalidomide, because the group that does best is the people who are MRD negative and stay on lenalidomide. Next slide. This is the most intriguing data so far about stopping lenalidomide after a long time, right? So this is from a big study called the Myeloma 11 study. In this study, patients had induction treatment and then they were randomized to have either a placebo or lenalidomide. And the patients who stayed on lenalidomide long term, They then looked at 2 years, 3 years, 4 years, 5 years of lenalidomide, whether there was a big difference in the people who were MRD negative. And what it showed is for the patients who are MRD negative on the top, there was less difference between the people who took lenalidomide for 5 years and the people who didn't. And I think that's kind of self-evident that if you're in a very good deep response, you're maybe not going to get as much benefit, but it doesn't actually tell you that you can stop lenalidomide. It might tell you that in a big group of people, the benefit was a bit lower after 4 or 5 years of maintenance, but it doesn't tell you that stopping is going to be better for you, because probably if you're tolerating and you're not getting unacceptable toxicity, staying on lenalidomide, even if you're MRD negative 4 years later, is still going to be better. But what it does show is in the MRD positive patients who still have detectable myeloma in their marrow, the lenalidomide patients do much better than patients on placebo control. So once again, doesn't really tell us what to do, but can be part of the information to help you make decisions out at this 4 or 5 year period if you're getting toxicity from your drug lenalidomide. I wanted to briefly talk about this, and I drew this by hand, but I think it's really, really, really important. Not all myeloma is the same, right? So yes, in a big trial, it's best if everybody gets to MRD negativity and has no detectable myeloma. But actually, some of my patients who've been in remission the longest don't even get their paraproteins to go away. They're a different type of myeloma. They have lower aggressiveness myeloma that's harder to get rid of, harder to get down to no detectable paraprotein, or even way off having no detectable myeloma cells in the bone marrow. And they're that group on the left. And I think many of you would see these paraprotein graphs over time when you have treatment. And you might see on this graph that at the beginning, the patient had a big paraprotein, it dropped with their induction treatment. Then they've had a transplant, it's gone down to this first plateau. That remission has lasted for maybe 4 years on no drugs. They've slowly progressed and then started a second therapy like daratumumab and Velcade, and remained, once again, the paraprotein hasn't gone away, but it's remained at a low level and very stable for a long period of time. This patient in this plot number 1 might feel really depressed when they go to their myeloma support group, because they might talk to their friends and they say, oh, what's your paraprotein? Oh, mine's some small number, 5. And the other people go, oh, mine went away straight away. And so this poor person feels terrible. They feel like they haven't done enough. They feel like they haven't got their myeloma into a deeper response. And yet this person's going to do exactly the same as the other person on the right, whose paraprotein goes away immediately, but then comes back a later stage and then goes away and comes back. And really what I wanted to express to you is these are 2 different types of myeloma, but one is not worse than the other. And it's just a reminder to me that as patients, you need to learn like your myeloma and be speaking to your doctor about what matters with your myeloma, because for some people, getting to plateau phase is a great response and actually a very stable and durable response. And if that patient kept adding drugs to try and drive it deeper and deeper, they actually probably make themselves sick without any added benefit in terms of controlling their myeloma long term. So I think horses for courses, but just be aware that there are these big differences between different groups of people. Next slide. And then almost finished, I just wanted to bring patients' attention to the fact that PET scans are now fully funded in Australia for myeloma. These 2 item numbers down the bottom, 61612, which means, and 61614, and you're allowed to do PET scans at any stage where it's going to inform treatment. So they don't actually limit how many you can do. I mean, PET scans expose you to radiation, so you don't want to have them all the time because of the risk to your body, but they can be used to help guide decisions. And this is a picture of a PET scan in a myeloma patient showing a liver mass, and then a PET scan afterwards showing lots of bony masses, unfortunately, but an improvement. So PET scans can be a really useful tool. We've only had access to them for about I'm guessing about 6 months, I think, something like that. And so we're still learning how we can deploy them best to help our patients. But I think if you've got a difficult question and your doctor doesn't know whether your myeloma lesion is active, for example, this is a time when a PET scan can be useful. And so I tried to write down here when we're starting to think maybe you should perform PET scan. This is just my ideas. This is not definitive. So, I mean, I think PET scans are very important when there are lumps outside of the bone marrow, which we call extramedullary myeloma. They're important to measure those lumps, to direct things like radiotherapy to them, to make sure the treatment has worked on those extramedullary plasmacytomata. Their PET scans are also really important, particularly in plasmacytoma-based disease, to confirm that all areas of the disease are asleep when you've had induction treatment and confirm that you're in remission. They're really useful when blood tests aren't working. So some patients don't secrete a paraprotein or have very low level paraproteins, and then PET scans are useful. And I think what I'm finding more recently when they're most useful is when CAT scans or MRIs are inconclusive and you're worried that a patient might have active disease or not. So we're using them in those situations at the moment. They're fully funded, so you don't need to pay anything for them. And then this is a summary, and I'm not going to get time to talk about BCMA-based therapy, but I think there are lots of talks about that, and I was more keen to talk about what practical skills are available right now for you to judge your myeloma and make good choices. I think now in Australia, we have really good state-of-the-art testing to generate that risk information. And we also have got growing access to MRD testing for bone marrows, and certainly up here in the eastern seaboard, we can receive samples. But it's really important to know that, like that graph that I showed you of the patient who didn't have the deep responses, that you are unique. Everyone's myeloma is unique, and no one test is better than good sense. And your good sense and your doctor's good sense in understanding things will beat all these risk tests, I think, every day. Deep responses are important unless they're not. So in some patients, reaching MRD negativity is just not appropriate. It's not what's needed. If they reach a plateau phase and stay in a stable plateau phase for 5 years, that's a good result. We know that risk can help making some decisions, but ultimately it's going to be better treatments that deliver better outcomes to us. And there are a whole lot of trials going on at the moment to try and figure out how those better treatments like bispecific antibodies and CAR T therapies fit into treatment to give patients better outcomes. And I'm passionate about MRD mainly because I like the democratization of care. So I think you should know what you want to know. Some of my colleagues criticize MRD testing because they say, well, we don't know what to do if you remain positive, or you can't stop drugs if you're MRD negative. And I feel, well, yes, that may be true, but actually I want you to know but my patients have wanted to know. And if you want to know, I think you should have the opportunity to learn this data and then make your own decisions. And I just think it's really important to say at the end that every decision is actually a mixture of toxicity from treatment, patient wishes, risk of the myeloma at the beginning, and how deep and how your response has been. And you can't make any of these decisions in isolation from all of that data, which means you've got to get to know your doctor, get to know your myeloma support nurses, talk, ask questions, learn as much as you can, which is being here, I hope. And hopefully that has given you some information, some of which you can understand, some of which will be a bit much. And it's the start of a conversation about how we can help you to make your best choices. And with that, I'd like to say thank you for asking me to talk. And the last slide is just some acknowledgements. Yeah. And I'd like to acknowledge my group, Professor Joy Ho and Tracy King and Edward Abadir and all of the people in my research group in my hospital, and of course our patients and our families who we wouldn't be here without. We're here to serve them. Thank you very much.
Thank you, Christian. Thank you, Christian. That was a really great start for our seminar series. I really loved early on how you identified that patients are people, not numbers. We get a lot of calls about prognosis and staging, and I really enjoyed how you could say that what matters is how they respond to treatment. So thank you so much. Apologies, we are having a slight technical issue with our live chat box. So please email your questions through if you can. We did have a couple of email questions come through earlier, Christian. So I know you didn't cover so much the bispecifics, but there were a couple of interesting questions. One was, is maintenance suggested after successful bispecific treatment for high-risk patients? I know you talked about it in our current standard of care. Are you able to comment on that?
Yeah, absolutely. Look, that's certainly what's being proposed in trials and in current trial design like Majestic 7. That's what's happening. I think most of the current trials continue bispecifics, often with a big effect in terms of immunosuppression. I suspect that's where we'll get to, patients having induction therapy with bispecifics and then having maintenance with less toxic drugs like daratumumab and lenalidomide. I think that's likely where things are going. But that will happen iteratively over the next couple of years as trials progress. They first need to show the combinations are safe and work, and then there'll be modification and tweaking of those combinations. But yeah, I think most patients need to stay on maintenance therapy. And I think otherwise you get emergent resistance. And unfortunately with myeloma, each time it comes back, it has the chance to develop resistance, which makes it inherently harder to treat. So keeping it compressed, keeping it asleep, if you like, with the least toxic agent is where most of our treatment paradigms are moving.
Particularly in that high-risk group like you identified. I think that's where we're heading. The other question that I thought was interesting is testing available in Australia to actually identify any of the specific markers, so the BCMA, the GPR, C5D, or the FCRH5, to know which bispecific would be most effective?
Yeah, really good question. Not routinely. Shirlene Sim is setting up an ELISA to pick up soluble BCMA levels. I mean, the thing about BCMA, and I had slides about this, I just decided to focus on risk instead. It's everywhere. So there is no myeloma that's BCMA negative that I'm aware of. I think it's 100% BCMA positive. And that's because BCMA is not just a marker of myeloma, it's a receptor that myeloma needs to survive. BCMA on the surface of myeloma cells receives critical life signals from other cells in the bone marrow to make it stay alive from molecules called BAFF and APRIL. And that's why you don't become resistant to BCMA therapy, very largely speaking, by becoming BCMA negative, because cells that shed their BCMA completely or have no BCMA on the surface don't get those life signals anymore. So to be able to do that, you have to be very mutated cell. Most resistance doesn't happen through that mechanism. It can happen by little mutations in the BCMA, but that means that it kind of wouldn't be a point in measuring BCMA because everybody would be positive. The other markers, FCRH5, I always struggle with these complicated ones. Glycoprotein receptor C5D. I don't think there's any testing available. I think that will happen once we get standard of care access to these agents. Just as we, for example, will set up an assay to measure CAR-T from patients once it becomes a standard of care, which will also be another bit of important information. But yeah, not routinely available at the moment.
All right. Thank you. In the interest of time, we'll move on. If you do have any questions for Dr. Bryant, please email them through and we can reach out to him with those as well. Thanks so much for your time today, Christian.
Thank you.
It is my pleasure to introduce our next speaker, who is Dr. Nathan Close. He is a clinical and laboratory haematologist in private practice at Greenslopes Private Hospital. He has experience in administering various treatments such as chemotherapy, immunotherapy, and cellular therapies, including bone marrow transplantation and CAR-T cell therapy. Dr. Close is an active investigator in bispecific antibody therapy for myeloma. He works with a focus on open communication to deliver expert, personalised care to patients in Brisbane and further afield. And that's why he's perfect to present for us today on My Voice, Shared Decision Making. Thank you, Dr. Close.
Thanks so much, Kath. Just triple checking I'm coming through okay. Wonderful. Technology is great when it works. Thank you so much for having me. It's a real honor, and I think obviously some great quality of speakers, and just really great to assist Myeloma Australia's wonderful work. So thanks for coming, thanks for listening, and especially thanks for having me. I've been asked to talk about shared decision making, and it's something that I'm really passionate about. We've heard about some options already available to you through risk assessment, and hopefully this just continues that conversation about shared decision making. And I thought I'd start by relating a quick story and start with some AI generated feet, which you can tell because the toes look really weird. This is represents a patient of mine that I had when I was a junior doctor in training. And this fellow was elderly. He had medical problems, including heart failure, a leaky valve that didn't work, and had an awful infection on his toe. And it wasn't responding to antibiotics, and it was getting to the stage where we'd have to do an operation to chop off his toe and probably most of his foot to save his life. But unfortunately, because of his medical problems, that sort of operation would be a life-threatening operation, and there'd be a decent chance he wouldn't come through. So just an awful rock and a hard place kind of situation. And as a junior doctor, I was mainly responsible for running the ward and looking after this fellow. And we just couldn't come to a decision together. Should we do the operation? Should he not do the operation? And we go back and forth about, like, should we pull the trigger, get the surgeon in and do it or not? And it wasn't until a very helpful nurse came by one day, and I overheard a conversation, and they were speaking about his dog at home, and we spoke a bit more, and it got me to asking, rather than do you want an operation or not, I asked him, well, what are your goals? What actually is really important to you going forward in the next couple of months? And it turned out his poor dog's being looked after by an elderly neighbor. He wanted to get home and see his dog one last time and take him to the beach if he could. He wanted to get some paperwork sorted at home, so his will and some other things that he needed to get sorted at home. So really what was important, that he could get home for a couple of days. And then if he didn't survive in the next few months, that was okay. His quality of life was decreasing. So it just completely changed the conversation. Rather than asking a medical question, do you want surgery? It came to asking a different sort of question: what's important to you? And then how could I make a medical program that kind of met those goals? And it just, perhaps that should have been more obvious to me as a doctor throughout training, but it for me became very clear that my role is not to administer treatments to diseases. My job is to look after patients. And so a key part of that is finding out what's important to people, and using our expertise as doctors to make a treatment plan that meets those goals, rather than treats a disease in a particular or arbitrary sort of way. So that's a bit of my background and why I'm so passionate about that. And I bring that sort of philosophy to the way I look after myeloma. Just a couple of quick disclaimers. Obviously, you're well aware comments regarding myeloma and their different treatments are general and may not apply to your situation. These are my opinions. This is not the best way to practice medicine or myeloma care. Your doctors, you and your loved ones may disagree, and that's okay. And shared decision making, as you can kind of tell by that little intro, it does involve some really big and difficult questions. Sometimes it's easier to ask, do you want lenalidomide maintenance or not, versus, what's important to you? Those are really tricky and big questions, and can bring up some really confronting sort of future sort of issues. So do the journey with your support network. That includes your family, it includes your GP, and make sure you seek help along the way. So in this quick talk, I'm just going to aim to cover 4 questions. We'll spend some time on the first 2, why shared decision-making and what is shared decision-making. We'll run through some practical things about how you can prepare for shared decision-making with your hematologist, and how do you kind of get the ball rolling and get engaged if it's not already happening. So in terms of just making a case for shared decision-making, well, of course, I wouldn't be a hematologist doing a presentation if we didn't get some evidence in there. So just starting with, shared decision-making is is when we do patient-centered personalized care. So this is care based on what's important to the patient rather than a disease-centric focus. There's some good quality evidence in this space, but this is one particular paper focused on multiple myeloma. And there was some evidence that it resulted in increased patient confidence, satisfaction with the treatment decisions, increasing trust in the healthcare team, increasing treatment adherence. Obviously, you're more likely to take the medication and continue taking it, not forget it if you realize why it's so important and why it meets your goals. Improved health quality of life was common, and even a signal suggesting an improved physical health outcomes. So these are, it's not just a nice idea, but it's a good medical option for care that results in improved outcomes. The stakes are high. We are dealing with, at the moment, an incurable disease, and the journey is long. The options are complicated, and I just don't see any other way to do it. Shared decision-making is, in my opinion, the only way to manage this disease, given the trajectory that we face together with it. So what if I say it's the only way of doing it, well, what are some other ways of doing it? And in terms of approaching your medical appointments and your medical care, I've kind of created this sort of spectrum, which is a bit arbitrary, but it hopefully gets the point across. And at one end of the spectrum, you've got a completely autonomous, self-directing patient. I guess at a real extreme, you've got a patient who doesn't even see a doctor. They've made their own decisions for their healthcare, and they'll figure it out. Or if they're engaging with a doctor, they're going to tell them what they're going to do after Googling. And then at the completely other end of the spectrum, you've got an authoritarian healthcare provider. There's no exchange of information. They're here to deliver the treatment plan to you, and your job is a passive participant in that process to say, yes, doctor, and do what is given to you. So shared decision-making sits within this spectrum. And obviously there are preferences that you or your specialist may have one particular way than the other. As a personal note, I sit a lot more towards the patient autonomy end of the spectrum. I love engaging with my patients and helping them make a decision, not to place the burden of them, but so that they feel empowered with the decisions that they're making. But shared decision making is anywhere within this spectrum. The other reason why shared decision making is important is because as we said, the decisions are complicated. And just as a really quick summary, this is not quite a comprehensive list, but in terms of the treatment options that are available to us in 2025, of course, highlighting clinical trial participation. In terms of PBS reimbursed medications, we've got several triplets. We've still got autologous stem cell transplantation, multiple lines of novel agents available, not including the chemotherapy salvage options. In TGA approved, but not PBS reimbursed options, we do have several, and including the cilta-cel, which is sort of obviously progressing in its PBS or at least federal funding reimbursement status, as well as multiple bispecific antibodies. We do have future therapies coming, and you'll hear more about them, at this conference and elsewhere. But essentially, we've got a lot of options to choose from. Now, what that means is two things. One is we need to engage with our patients to help decide about them. But the other is you're going to need your specialist help. Honestly, we do our best to stay on top of these things ourselves. But from a realistic point of view, it's going to be very difficult for even an expert, myeloma patient to try and keep up with what's going on, because there's a lot going on. So why shared decision making? Your healthcare team should be the experts in the myeloma and the treatments available, but they've not encountered you before. You're the expert in you. And as we've heard a lot today, already, every patient with myeloma is different. And I guess I just wanted to highlight here, this is more than just the biology of the myeloma, like as in your own case of myeloma, but you're the expert in you. You're the only one who knows what you want. And the treatment plan shouldn't be aimed at treating myeloma. The treatment plan should be aimed at meeting your goals. Without discussing the disease, the treatment options, the potential side effects, assumptions can be made about those goals, leading to mismatched goals and suboptimal outcomes. Everyone is different, and so don't assume that your healthcare knows what you want and what's important to you, and neither should your healthcare assume that they, know what you want and what's important to you. It's especially early on in the treatment course, of course, efficacy and good outcomes, deep responses, maybe, etc. These are very common treatment goals, but they're not the only goals. And thinking about other things that's important to you is a key part of that shared decision-making process. So that's hopefully I've made a bit of a case for why we should be doing shared decision-making. And then this is just a bit of a summary on what that process involved. So in my mind, shared decision-making involves a number of steps. The first step is having an expert healthcare team who understands the treatment, and that's going to include your specialist, it's going to include your myeloma specialist nurses, your other support and information team, including Myeloma Australia. And that's the first step. The next step in the process will be engaging with an expert patient who understands themselves. And that means someone who understands their treatment goals and their personal values. And that's your half of the equation. Now, you can have those two people present in a room, but if they don't share their knowledge with each other, that is not going to be helpful. So the third step in the process is a knowledge exchange. This takes time. So being realistic about some time for education, to be able to learn about your disease, the options available, the potential side effects, but also giving your doctor time to understand you and listen to you, and what's important to you is that third part of the process. Once there's been sufficient time to exchange knowledge, and obviously that's an ongoing process, together you're then able to design a treatment plan which meets the goals. And it's important that that is not done with shortcuts. And I think, just to highlight, some cases that might be examples of what happens if we take a shortcut one way or the other. A classic one is doctors making a treatment plan without considering the patient's goals, and that can result in a reduced quality of life. There was some excellent, just as a quick story, there's excellent data, especially back when we only had doublets available. We were using bortezomib by itself, that the number of doses of bortezomib that you got was directly related to your outcomes with the disease. And so maximizing and using every single dose you could get on the PBS was really important. We had a patient that, unbeknownst to us, was also a concert pianist. When you actually got down and sat and listened to him, he wouldn't mind, 12 months less progression-free survival if he could continue to play his grand piano for his grandson, and making assumptions that a maximized progression-free survival was what was most important to this patient would miss the potential side effect of neuropathy that could occur with progressing doses of bortezomib, and therefore not meet his treatment goal. So that's how doctors could make a shortcut and assume and have a poor outcome. Similarly, it's also possible to make assumptions from a patient's perspective. This is not getting the information that you need to get from the expert healthcare team in order to meet your goals. So making assumptions about side effects or outcomes from certain treatments without actually knowing what the possibilities are. I've have a privilege of meeting a wide range of patients from lots of areas of life and different sort of background health values. And it's not uncommon to come across patients who, before they've even heard about myeloma treatment, will be refusing treatment. So I don't want chemotherapy. I don't want, lose my hair and, this kind of thing. But actually, when you engage with these people and you hear what they want to be healthy. You know, they don't want their health to be affected by, you know, this or that, or they're worried about particular side effects. And so when you can run them through what to expect on treatment, you can actually come up with a treatment goal that aims to try and maintain their treatment plan, and you can actually aim to meet their goals. And you'll find out that their shortcuts they're taking by refusing treatment and not understanding about them is actually not meeting their goals worse than if they were to receive the treatment, which would actually maintain their health in a better way. So just to highlight a couple of pitfalls if we don't do shared decision making. So hopefully I've made a bit of a case to you about why we need to do shared decision making and then what it involves. In terms of participating in the shared decision making process, first I'll talk about some aspects that you can do to prepare. The first is not an easy one, and one that, you know, I do recommend you do with your loved ones and other support network, is taking time to think about what's important to you. And this may be, you know, fighting the myeloma with everything you've got, putting up with any potential toxicities to get the deepest and longest response possible. But there may be some other things that come up in that conversation as well. This also includes what quality of life means to you. And again, these issues take on a bigger role as we progress in the myeloma journey and deal with people later on in the course with relapsing disease. But, you know, quality of life it is different to different people, and that includes potential side effects, independence, and other, you know, other things. You know, really being honest with yourself and asking the question, does treatment effectiveness and quantity of life really trump everything? And are there more important things in life than, you know, squeezing every month of progression-free survival out of a treatment that's possible? And I've just, you know, given some examples here, but are there certain activities, lifestyle considerations that are important to you? And that might be, you know, being able to continue to work, taking time off to travel, having time off treatments for other reasons, and side effects that in particular may affect hobbies and passions. Finally, is just, you know, it's an incredibly vulnerable position to, you know, to come to an appointment. There's the stress of receiving your results, you know, the results day anxiety. There's the anticipation of the treatment and other side effects that might go on in the day. There's the busyness of hospital parking and all of that. But just being ready and set in your mindset that, you know, as we heard just before, you know, we're here for you. There's nothing more important on our day as your myeloma specialist than coming and listening to you and hearing about what's important to you and your treatment goals. So being prepared in your mindset and in your attitude to ask questions about the treatment plan and mention those things about quality of life is something that you can just mentally set yourself for coming to your appointments. When you're trying to start that first part, you know, either at diagnosis or facing a relapse and a change in treatment, there is a bunch of information that you need to know about the treatment in order to know if it's going to meet your treatment goals. And this is all information that your healthcare provider and the myeloma support nurse, etc., should be able to provide you with. We won't run through this in great detail, but just some high points. You know, how effective is the treatment expected to be? How long before we might need another treatment? What's the chances that it might respond at all? How is the treatment given and where is it given? You know, at home, in the day unit, tablets, injections, infusions. What's the treatment schedule? Do we have times off? Is it continuous until relapse, or is there a defined period and then it stops? What are the expected side effects and what are the possible side effects? How can I expect to feel whilst having treatments? Can I take a break or miss? What happens, so what comes next? What happens when the treatment stops working? And is this clearly the very best option, or is it equivalent to potentially other options? And should we be weighing up multiple options together? So having taken some time to prepare for shared decision making and think about the type of questions that you need to know and the information you need to know to engage in that process, I thought I would just highlight a couple of practical points about how do you actually start in this process, because I do acknowledge, like I said, it can be difficult to get the ball rolling if that's not how you feel the conversation has been up to this point. And I will say the main responsibility rests with us. We're humans as well, and there's busy clinics and the stress of dealing with stuff. It's no excuse. As we've said, there's nothing more important about the care we provide than you. You are the reason why we're doing this, and we're not treating your myeloma, we're treating you. We have a saying at Brisbane Blood, which is what matters to you matters to us. And the key onus is on your healthcare providers to set that tone and get the ball going. However, you also are there and need to prepare and engage in that process. And so taking the time to prepare is a key part of what you can do. The other sort of thing that you can do to assist in this process is to bring your support persons with you to the appointment. As I said, it can be hard to remember your list of things you've got to get done for the day, and having that extra brain with you can help engage in that process a bit better and be a bit more of a advocate for you as you engage in that process. And finally, as you can tell, these things take time, and from a really practical perspective, sometimes not every appointment will we have time to discuss all of these issues. So just flagging with your healthcare team in advance that, there is some bigger picture stuff that you need to, that you'd like to engage with. If you are in the public system and that you're dealing, with registrars coming or junior doctors, and then you've got other times where you're seeing the consultant, trying to flag with the team that you've got some bigger questions to run through, just prepares them so that they've got the time to allocate to you if possible. Yeah, just to reiterate this point, to feel empowered, we're here to treat you and your myeloma. So that was it. That's all I had to run through today. Sorry, very intangible sort of talk, not a lot of data on myeloma and its treatment, but hopefully some thought-provoking things and just something to empower you and make you think that you are the reason why we're here, and this is a long and complicated journey, and one size doesn't fit all, and the only way I believe to get through it is to engage with your team and help make those decisions together, and that way try and meet your treatment goals as best as possible. So that was all I had. Thanks very much.
Thank you, Dr. Close. That was amazing, and I'm really sure that our members will find that very empowering. I'd like to probably remind, which you did in your talk, thank you very much, but in terms of being prepared, on our nurse support line, we do have the benefit of time that your specialists and even your nurses in the day unit sometimes don't have. So please book a call on the support line. And we can talk through some of those concepts. What are your values? What are your goals? What can you expect from treatment to try and help you make those decisions, and then go into your appointments armed with that information and with a little bit of that up your sleeve. I'm not sure if you're happy to kind of answer. It's a question in a roundabout way, it's almost like a case study, but we had an inquiry from a lady in WA who was diagnosed back in 2019. Had CVD as her initial treatment and had a partial response to that. 6 months along, numbers were moving, and she went on to DVD at that point and has remained on that, on maintenance daratumumab, up until now, where now her numbers are increasing again. And her question was sort of, where to from here? And I thought this might be a nice point for you to maybe say, like, how might she approach that discussion?
Yeah, that's a really it's a perfect scenario that incorporates clearly we've got all the medical information there, and no personal information, you know. So my first approach would be to you know, find out, you know, where this lady's living, how close she is to the day unit, how easy accessible, you know, infusional medications are, because we've got a couple of options that we'd sort of consider. But you know, basically the conversation would be around a lenalidomide backbone medication regimen that would either incorporate elotuzumab as a infusional medication along with the lenalidomide, or carfilzomib being KRD, the other protocol. So we'd approach this by looking at the data together. It's going to be difficult to compare those trials head to head because they are very different settings where they were the registration studies for those two trials. But talking about the expected efficacy, and I'd be really positive. You know, I've had a lot of people do really well with lenalidomide-based therapies in these non-len exposed people for third-line therapy. So be really positive approaching that conversation, and then talk about elotuzumab versus carfilzomib, what to expect when you're on those infusional medications. But both of them are IV. Elotuzumab's fortnightly, carfilzomib's you know, in the KRD regimen is twice weekly. So that's a lot of hospital contact. There's maybe comorbidities with heart stuff we'd consider with carfilzomib. So yeah, a wonderful example where we then sit down, run through, you know, what's important, like hospital contact times, particular side effects, and then, you know, run those efficacy numbers together and see if we can match all that together and make a decision. But there are other treatment options as well, but those would be my two picks. Yeah.
Yeah, perfect. Thanks so much. We'll get that information to her. I'm sure she'll watch today as well. Thank you so much for your time and for a wonderful talk. Thank you.
You're welcome. Just to say again, thank you so much for having me. And to Myeloma Australia, we really appreciate your support for my patients and for everyone. Thanks a lot. A real privilege.
Thanks so much. So we are going to just have a short break now, 5 minutes. Just stretch your legs, make a cup of tea, have a drink, have a stretch, and we'll be back with you in 5 minutes. We've just got some slides to cover in the break with messages and some news from our sponsors. Thank you.
Welcome back, everyone. I hope you had enough time to grab a quick refreshment and stretch your legs. As Kath mentioned before, my name's Shani Dickinson. I'm one of the nurses over in WA. Now, good news to start off with, the live chat is working. So if you have any questions, that function is available for you guys to pop a question in. I'm very excited to introduce our next speaker, Brent Cunningham. Brent is an accredited exercise physiologist and PhD candidate at the University of the Sunshine Coast. Brent has worked clinically for over a decade and his research focus is on exercise oncology and how exercise variables are monitored, adjusted, and individualized to accommodate psychological, functional, and physiological factors for individuals across the cancer continuum. Brent has been involved in multiple myeloma and exercise trials since 2019 and is passionate about helping develop exercise services and education for people with multiple myeloma. Today, Brent is talking on My Movement, individualized exercise intervention. Thank you, Brent.
Thank you, Shani. And thanks to Myeloma Australia for having me. I'm really looking forward to presenting about how you go about individualizing your exercise wherever you are on your journey with multiple myeloma. So before we get started, as Shani mentioned, I'm Brent, and I'm an accredited exercise physiologist and have had the great fortune of working with a lot of people with multiple myeloma since 2019. I was working on quite a big landmark study that we did here in Brisbane, looking at how using various different types of exercise for those with multiple myeloma impacts their quality of life, as well as things like their bone strength, fitness, and bone pain. And so we had some really wonderful outcomes as a result of that study. And that's led us on to a further study that we're currently undertaking. And that's called the MyX Impact Study, which I'll provide a little bit more information at the end about. But I don't want to go through and sort of provide any like overly data heavy content today. So it'll be really more a conversation about things to consider and ways in which you can go about adjusting your exercise, or if you're just getting started or getting back, some of the key considerations that we can go through and think about when we're trying to do that. And for those that may not have ever heard of an accredited exercise physiologist, we're an allied health professional, and our whole shtick, so to speak, is really about using exercise to help navigate different forms of diseases. And that's really the tool that we use. So we're an allied health profession and work alongside nurses, doctors, physiotherapists, occupational therapists, and sort of really well trained in being able to use exercise clinically for your particular goals and condition. So when it comes to exercise, we often know that there are unique challenges, especially around diagnosis or around treatment with multiple myeloma. And I've drawn on most of the challenges that I've seen quite commonly with multiple myeloma. And they're really centered around, like, is exercise safe? And this is both from like your individual level, but traditionally also from the hematologist and nurse level as well. We didn't have a lot of information to inform if it was safe and which particular aspects of exercise weren't or were safe. Also, a lot of people don't necessarily know exactly what they should be doing, where to start and where to go to from there. And then the other challenge that we see with all forms of cancer, but quite commonly in multiple myeloma, is there are just so many days where you experience fluctuations in how you're feeling, the symptoms you might be experiencing, especially around treatment, and what you do on those days. Do you rest or do you exercise? And really uncertainty as to what to do when those challenges arise. So I wanted to focus a little bit more on solutions today and some key considerations when it comes to trying to navigate these issues. So we've been fortunate enough with the MyX study to understand that exercise is really safe in multiple myeloma. And there's also a number of trials worldwide that have demonstrated that it is safe. What we understand is that it's safe if we're using supervision primarily, but independent exercise, so doing it in an unsupervised way, can also be safe, provided that you're adhering to some guidelines around the best way that you can incorporate exercise and keep yourself safe, which I'll talk to a little bit more today. And then we also understand now that really exercise can be adjusted based on how you're feeling day to day. And it's not necessarily going to result in you having any less of a positive outcome. But really, in order to stay safe and to keep you exercising and engage with that process, being able to adjust how much or how little you're doing day to day is going to be a really great way to sort of match those fluctuations that you might be experiencing. And fundamentally, when it comes to exercise, in order for our bodies to adapt and change over time as a result of the exercise, we want to make sure that we're progressively making that exercise more challenging. But we want to do this in a very slow way over time so that we're able to monitor how we're responding. And that also just gives us a longer time horizon in terms of the ways in which we can progress and keep exercising. And there are a number of ways in which we can progress exercise. Sorry, I clicked the wrong button. Alrighty, so where to start? What I'm going to do over the next few slides is talk about some of the key considerations as an exercise physiologist that I have when working with someone with multiple myeloma. And I thought these might be some food for thought for you as well around some of the things to start to consider that might inform some of the aspects around your individual needs when we're trying to prescribe exercise, or some things for you to consider about what might or might not lead to us needing to adjust various aspects of your exercise. This can be things like your lifestyle, your hobbies, activities that are important to you, what you're trying to get back to, maybe what you're trying to keep doing, or if you're starting from scratch. And the photos here are some of the participants from the original MyX study that we did in 2019 to 2021. So these are some of the wonderful people that went through that study and helped us understand that it is quite safe and really effective. So here, there's just a little bit of a flow chart process. And whilst this isn't specific to multiple myeloma, it is quite a good process by which we go through as exercise physiologists or anyone working in an exercise context with people with cancer, and consider the various aspects that are unique to them, such as where they are in their cancer journey. With multiple myeloma, things that we want to consider, like your current treatment and the current treatment regime in terms of, you know, how many times you're having to go and receive treatment, and the frequency of this. Also, other considerations are if you have any particular lesions, whereabouts these lesions are located. And in addition to that, are those lesions stable or unstable? And are you currently receiving treatment, such as a meta or a bone hardening agent for these? As well as other side effects that you might have experienced. Peripheral neuropathy is something that we consider quite heavily with regards to treatment, such as Velcade. It can sometimes affect the sensory information you're getting from the feet specifically. When it comes to doing exercise, we want to make sure that you're safe and we're able to put you in positions or set you up for success in whatever exercises we're prescribing you. There are a number of other considerations there, but also just if there is anything else going on in your life and with your health. A lot of people have a number of different conditions they might be managing. And as much as you have multiple myeloma, we need to be looking at you as a whole person and the unique needs that you have. So this is all really important information that we consider as exercise physiologists, but also things for you to be considering in terms of how we might be approaching exercise for you. The other really important aspect of exercise is your particular self-belief ability around what you're doing. And also if you have any concerns or there's any apprehension to certain types of exercise. And a big component of this too is your knowledge. So what you know or don't know about exercise, and being able to be informed and have an understanding of what's safe, what you can be doing, the reason you can be doing it is really, really empowering in your ability to engage with exercise. And at the bottom there, it talks about goals and preferences, which really plays a big role in the work that we would do in terms of developing our exercise program for you as exercise physiologists. We want to make sure it aligns with something that is important and meaningful to you, and that the way we're using that exercise is also meaningful to you. So the number one strategy here is starting low and building slow. So when we're starting exercise, we want to consider what the background is that you're coming from. Have you previously been exercising? Are you returning to exercise? Or is it something that you're trying to maintain or completely new to? So we want to explore how we can build upon this in terms of things that you're currently comfortable and confident with, and then also what's within your current capabilities at the moment. So is this something that whilst you're on treatment, you maybe don't have the energy level or say the balance capabilities for at the moment? And so we want to try and meet you where you're at and then build up from there. The other important thing when it comes to prescribing exercise or just considering the types of exercise that you'd incorporate are doing things that are important to you, meaningful to you, and that you enjoy. We know foundationally that you're more likely to do the exercise or the form of exercise that you enjoy. But I'd like to talk a little bit around some ways in which you can maybe sprinkle a little bit of exercise into your life that may not be the exact type of exercise you enjoy, but we know is going to have positive effects for your health and wellness. And this choosing exercise that is important to you really does come back to what are you doing the exercise for? What are your goals? Because this will really help inform the type of exercise you're doing, such as aerobic exercise training, where you're trying to improve your fitness and how well and efficient your heart and lungs work in supplying your muscles with blood. Or are you trying to improve your strength? And so you're doing more of a strengthening based exercise. Or is it where you're trying to perhaps target more of your bone and bone strength? Or is it a combination of all of these? These are really important considerations and things for you to be thinking about as well. And also, if there are exercise modalities there that I've mentioned that you don't quite know about, really great to start to build your understanding of those if it is something that you're interested in exploring. I might have jumped ahead. Sorry about that. Okay, and another common question we'll get is how much exercise should you be doing? And so we have a number of guidelines, both nationally and internationally, around these particular numbers. But I like to refer to these as guidelines rather than guardrails. The reason being is that everyone has unique needs. And as I mentioned, capabilities and capacities, and this changes at different times along your journey with multiple myeloma. So from a broad health perspective, it's generally recommended that you're getting between 150 minutes to 300 minutes per week of moderate intensity activity. So this would be something where it's relatively huffy-puffy. You could have a conversation, although it wouldn't be quite pleasant. And this can be in the form of things such as walking, cycling, and any sorts of sports that you might do, such as going and playing tennis or something along those lines. But it's generally an activity that's associated with that type of intensity. And usually to accrue this, it's best that you're doing something every day. But this isn't necessarily an option for a lot of people. And I'll touch on some other strategies that we can use as well. Another aspect to consider is the intensity that you're doing the exercise at. And so somewhere between 75 to 150 minutes of vigorous activity per week can occur in place of that 300 minutes of moderate, but you can actually use a combination of both of these. And the other aspect that's quite often overlooked is incorporating some type of strength or resistance training throughout the week as well. And as I mentioned, these are guidelines, not guardrails. And so for some people, it's completely unrealistic to be trying to get this much exercise. And these are just particular, time periods or effort levels that you can look to progress towards. But you might not necessarily reach them. And some people might exceed these and other people might do a lot less, but it's all about making sure that that's fitting and working for you. And along the way, making sure that it's safe and enjoyable with regards to the exercise we're selecting. And as I mentioned there, it talked about moderate effort, vigorous exercise, and vigorous intensity. And a lot of people might not necessarily have a frame of reference for how effortful that should feel or how hard they should be exercising. And it can be quite challenging to give a sort of general blanket rule as to the effort that you should be exercising at. But what I've popped here on the slide are two particular scales that we commonly use in exercise prescription that really are subjective. So it's based on how you're feeling in your perception of the effort. And the reason we like to use these is that day to day, depending on how you're feeling, and that can be influenced by a whole host of reasons, your subjective effort, provided that you're considering the descriptions there of moderate to somewhat hard, you might end up doing a little bit more or a little bit less, or you might end up doing it a little bit harder or faster or a little bit slower. And that's absolutely okay, because each and every day you're trying to work at what feels like a moderate to somewhat hard effort for you. And by no means does it have to be somewhat hard or moderate. It can be light to moderate. And there are other times where maybe it's a little bit more on a somewhat hard to a high intensity. But as a general rule, if we're considering the moderate intensity effort, somewhere in that moderate to somewhat hard effort range, or a 5 to 6 out of 10 on a 1 to 10 scale, can be a generally great place to be centering your exercise intensity around. And that's predominantly more associated with any sort of aerobic exercise you're doing, anything that's getting you a little bit more huffy puffy. When it comes to strength training, what we try and do is make sure that you're exercising or doing enough reps of an exercise to get close enough to you not being able to do any more reps of that exercise. When we're getting used to exercise, it'd be really hard to sort of know what might be the failure point at the point at which you can't do any more repetitions. But as a general rule, we're wanting to try and have you exercising and stopping somewhere around where you feel like you can only do 2 or 3 more repetitions. It's absolutely okay to do less. And we actually have some evidence to show that even being a few more repetitions, such as 5 away from not being able to do any more, does have very, very similar results to stopping 2 or 3 reps away from failure, or even going to failure. So we've got a lot of options up our sleeve, but I just wanted to give you something tangible today as a little bit of a benchmark for how effortful you should be exercising. And this comes back to you as well. It's really important that we consider how you're recovering from exercise session to exercise session, and then be adjusting this intensity accordingly. If you find that you're having a hard time recovering, or in some cases you can feel really wiped out as a result of exercise, that could indicate that maybe we're exercising too intensely, or more often than not, maybe we're doing a little bit too much too soon, because it does take time for our body to build up and us to adapt and build our capacity over time. And this is an area of research that I'm currently exploring. And so whilst we don't have a lot of exact evidence on how we do this, we are predominantly operating off some theories around navigating the ups and downs associated with multiple myeloma and the treatment. And this is something that I'm diving into a lot more with the current MyImpact study. So this idea is that as we go through treatment and just generally being a human, we're going to have these various different periods of up and down. And as this can be as a result of poor sleep, pain, stress levels, just general energy, fatigue, a whole host of reasons. For some days might feel a little bit lower in terms of your readiness to exercise. And other days you might feel quite ready to exercise and that you're in a good mood and things are feeling great. We also know this can be heavily influenced by your treatment as well. And so this little visual representation here is showing you, it uses infusion, and this is just a generalized figure that we have, and it's not specific to multiple myeloma. However, what it's showing here is the different lines associated with the different colors, and how these can change day to day. And what we're trying to do over the long term is match your exercising effort to the days on which you feel your readiness is high, and then also try and bring the exercise effort down on the days that you're feeling that your readiness is lower. And here you can see commonly after people have gone through treatment and they've maybe started to bounce back a little bit if treatment had an effect on them, the readiness is a little bit higher, but generally what's happening is their they're not necessarily adapting. And so by the time their readiness is high, they've not necessarily adapted to that. And so what we're trying to do is with your exercise, and this is something that you can do on your own, is on days that you're feeling great and things are feeling well, you can generally do a little bit more exercise or with a little bit more effort than on the days that you're not feeling well. So we want to try and still incorporate some type of exercise if you're a little bit lower on that readiness level, because over the long term, if we think about these squiggly lines, whilst we see these big waves, over the long term, that's generally going to be trending in an upward direction. So you're still getting somewhat of an important exercise dose, regardless of how you're feeling day to day. You want to try and work with those waves rather than feel like you've got to do a certain amount, even though you're not feeling up to it. And a common question we get, and this was also quite a common consideration by hematologists when Jenny did the original MYEX study, and we're interviewing a number of people about the concerns they had and particular areas of interest, is lesions. And so what do we do when we have lesions? So we know that provided your lesions are stable based on your imaging and your specialist advice, and that perhaps you're undergoing bone hardening medication, that we can exercise areas that do have lesions. But we have quite a few rules around this as exercise physiologists, and that is not exacerbating any current bone pain, progressing very slowly, and not necessarily adding any particular load at the start. And over time, as you're responding well, we might make that exercise a little bit more challenging. And that's for things such as strength training. When we're targeting more of a bone-specific exercise and we're doing some exercises called impact loading, we would generally recommend that you do this in a supervised environment, at least initially, whilst you're getting some education and having someone monitoring how you're responding in order to progress you safely. And so that would be something which you would talk to an exercise physiologist about, or a physiotherapist. But generally, provided that your lesions are stable and you're progressing your exercise slowly and you're not exacerbating pain, or if you are experiencing some pain, you're talking to your hematologist and you're regressing that exercise, it is really safe to be able to exercise. This is something that you would need clearance for and guidance from your treating hematologist about this before you commence, and something that would be worthwhile just checking with your hematologist about along the way. We want to generally avoid any exercises that would put you in a position where you might have a fall. And so usually we would do things where you're in a stable or well-balanced environment, and choose exercises for you, and also for yourself, thinking about exercises where you feel sturdy and safe in the way or position that you're doing them. And then also exercises that you can do with control. So anything that is moving rapidly or it's not able to be controlled, the speed, that's when we can potentially be at a little bit of a higher risk of having something untoward happen. It's just something to consider there when you're selecting the exercises. A really simple example could be opting to do something seated rather than standing if you're just not quite feeling sturdy enough in the standing position, or maybe holding on to something while you're doing the exercise to just give you a little bit of external support. And as I mentioned earlier, we have those 150 to 300 minutes per week recommended, but that is, and it recommended you're trying to do 30 to 60 minutes per day. And that can be an overwhelming amount of exercise to consider doing. And sometimes, with life, we don't necessarily have that huge amount of time. What we've started to understand a little bit more now is that we can actually break our exercise up throughout the day, and it not necessarily be any less effective than if we did it all at once. And so here, this is an image with a concept that's we're slowly understanding more around, called exercise snacks. So this is throughout the day where we might do very, very short duration. You could even be considering 1 to 2 minutes of exercise. And that exercise might be done at more of a somewhat hard to hard intensity, or even a little bit more vigorous, but it can be incorporated in something that you're already doing. And that could be if you're walking upstairs and you have the capacity, just trying to walk up those stairs with a little bit more vigor or a little bit more intensity. Or some examples are, some people will just march on the spot. Other people might do what if they're doing some type of activity of daily living, such as vacuuming, really crude example there, but they're trying to do that with a little bit more effort for 1 to 2 minutes. We've seen in some large data sets that it actually has quite a significant impact on some of the risk factors associated with cancer. And this is also testament to maybe you're not doing the exercise snacks, but you might, rather than do 30 minutes all at once, you might do 15 minutes in the morning or 15 minutes later in the day, or maybe even breaking that up even more. Or across the week, you're just slowly trying to accumulate some more exercise in times that you have available. These are all strategies that you can use that mean that you're able to get that dose, but it doesn't necessarily have to be all in one big lump sum. And I'm actually coming to my final slide. This is where we're talking about some approaches that you can investigate if you're wanting to try and get a little bit more advice or guidance around how to exercise while you've got multiple myeloma. And I think in the first instance is talking to your hematologist if they currently know or trust any particular exercise professionals, and this could be physiotherapists as well, that provide services to people with multiple myeloma, or if there are any particular programs, community-based or hospital-based, that they have access to referring you into. And over time, we'd really like to be able to sort of have a little bit more of a registry or database with Myeloma Australia established for you to find this information. And the other approach is to go on to the Exercise and Sports Science Australia website, which I've provided the link there for. And there's a find an exercise physiologist function. So you can search for exercise physiologists in your area. However, just what I would recommend doing is, because there's not necessarily an explicit filter to say that they have experience with multiple myeloma. So I've put a few questions there to consider that you'd want to talk to them about prior to maybe engaging in exercise services with them. And it's if they have experience and understanding of multiple myeloma, where we're still developing a lot of the evidence around sort of the best ways we can go about working with people with multiple myeloma. So it's really important that they feel confident in their ability to work with you and understand you and your particular individual needs, treatment needs, and the safest ways to be exercising. And also, in addition to that, are they aware of lesions and what they mean for exercise? And are they able to also give you the knowledge and education to be able to take away and exercise safely on your own without needing to rely on that exercise professional indefinitely? And so there are some great strategies through the enhanced primary care plan through your GP, where you may be able to get subsidized visits across a calendar year to see an exercise physiologist as well. So that can also be a way in which you're able to have a touch point less frequently throughout the year, but you've still got some expert input in help guiding you. And as I mentioned, we're currently underway with another myeloma study, exercise study in inner Sydney, so at the Chris O'Brien Lifehouse, and then also in Brisbane, where we're doing a 9-month exercise intervention, primarily looking at a little bit more bone-specific targeted exercise. And so I've put the website there in the QR code, a little bit of a shameless plug about this study, but we're currently still recruiting. And yeah, very much interested in anyone in those areas that would like to be involved, expressing interest, and we will give you a call and have a chat to you about the process. We're sorry that it's not available in a wider range of areas. And I know Sydney is a very big place. So if you're in Sydney, yeah, it is around the Chris O'Brien Lifehouse. So yeah, more than happy to field any questions that anyone has about that. But more information about the process and overview of the project is on the website there or via that QR code. And I want to thank Myeloma Australia for giving me the opportunity to come on today and talk to you about some of the considerations when it comes to individualizing exercise. It is a huge topic to unpack. So I'm more than happy to answer any questions that anyone has, or take any follow-up emails down the track. So there's my email address, and also the MyX Impact website, where you can get in contact with the research team as well. Thanks very much, everyone, for listening.
Thank you very much, Brent. That was an awesome introduction to exercise individualisation. It is a massive topic, as you said, and unfortunately, because it is a massive topic, we've run out of time for questions.
Oh, I'm so sorry.
No. It's getting the information out there for everyone is our priority. But if anyone does have any follow-up questions, you can either email Brent directly via the details he's provided, or you can email the nurses inbox and we can forward them to him.
Please do. Thank you.
So thank you very much. I'm now going to handball to Kath, who's going to introduce our lovely next speaker. So take it away, Kath.
Thanks, Shani. We've come to a point in the program where we thought it would be nice to hear from one of our members. And so it is my privilege to welcome you to Laurie, or introduce you to Laurie. So I had the pleasure of connecting with Laurie via our online statewide support group a couple of years ago. He's one of our New South Wales members. He joins our statewide group on the regular and always did. And then he was actually instrumental in getting a local support group set up in his area in Shoalhaven as well. We just wanted to have Laurie come on today just to talk to us briefly about when he was diagnosed and sort of where he is at in his treatment journey now. And then we've got a couple of questions just to talk through because he's quite the proponent of exercise physiology and how that supported him in his treatment. But hi, Laurie.
Hi, Kath. Yep.
If you're happy, can you just give us a little brief intro as to about your myeloma and when you were diagnosed and where you're at now?
Sure. I just feel that I'm a bit of a late starter. I didn't start finding out that I had myeloma until I was 82 years of age. It was my local GP that found it in a blood test, and I've been having treatment since November 2021. I'm now in my 5th cycle of treatment, and I've been along the bortezomib and the daratumumab, and I'm now on the carfilzomib. But I am having a little bit of trouble with side effects such as extreme tiredness or fatigue. But I've kept that up, and in the middle of my treatment, we started a gym at the cancer clinic, and I joined that. So I've been at the gym for about 12 or 13 or 14 months now, and it has made a big difference. Both the exercise part and the ambience of the group that's there. I think the amount of times we laugh and giggle and do things, it's a wonderful therapy. After we finish the an hour or two at the gym, I usually go for about an hour. We sit down and have a coffee together and compare all our ills and quaints and so on. And it's a real good, make me happy day. I think it's been a bit of a long trip, and for me, a bit bewildering because I didn't know anything about it at all. But thanks to Kath and lots of other people have helped us a lot and put us on the track. I didn't have any, what do you call that other one where you have your parts renewed?
The transplant?
I didn't do that. I was told I was too old for that. But I am going along the rest of the way and very happy with the haematologist and particularly the Cancer Care Centre at Nowra. It's a pleasure to go to and a super happy place to be at.
Excellent, Laurie. I had the privilege of coming and watching Laurie and his team at the gym, and they worked really hard. It was impressive to watch. I guess it follows from what Brent was talking about, because it's led by exercise physiologists, and they very much monitor you individually, don't they? And they work on different programs for all the people that come through. Full assessments, yeah.
Yeah, they do. And I was going up on the scale. We have a weekly sheet of everything we have to do, the types, how many times to do it, and so on. And then about 3 weeks ago, I got quite sick with a rhinovirus, which knocked me around a bit, and I lost about 6 kilos in a week. So I went back, and the physiotherapist said, "Oh no, you're going to start from the beginning again." So I didn't mind, and I got there and started to do my exercise and felt a bit stronger than normal. So I put in 20 instead of 10. Well, I got reprimanded for that. But I thought maybe that's good for me to keep an eye on it and don't get carried away. So it is a very controlled thing, and I enjoyed Brent's talk, seeing how controlled his system is. Ours is very similar, and it's another good feeling that I've had. The other thing was the protein lady. What do they call
The
it?
dietitian?
Yeah, the dietitian. She's been a big help too, just recently, and trying to get my weight back up again. And I'm looking forward to getting back to what I was, and yeah, continuing on with a bit of a stronger thing. Yeah.
Excellent. It's worth me mentioning as well that, Laurie, we've got My Greatest Walks coming up on Sunday the 30th, and they're our big awareness a walk for myeloma, Myeloma Australia. You can check the website to register. There's around 30 walks around the country. If there's not one local to you, you can sign up and walk where you want. Laurie is the leader of a group local to where he is. So we're glad that you're on the road to recovery, Laurie, after that virus, and you'll be right to walk on the Sunday.
Oh, well, the inspiration there is fish and chip picnic at lunchtime. So we're walking by the seaside at Greenwell Point, and last year we had about 35 members come along, and we wore our Myeloma Australia t-shirts, and it was a very nice day. So we're looking forward, we hope, to good weather and a bit of a picnic at lunchtime.
Excellent.
So hopefully it works well this year.
Thank you, Laurie. Thanks so much for being here and just for sharing a little bit of your story with us. It's just important to hear that patient voice, I guess, in the midst of all of us talking. We heard that earlier, that although we might be the experts in one side of things, you are definitely the expert in you. So thank you for sharing your time with us today and your story. Thanks, Laurie. We'll hand back to Shani.
You're welcome.
Thanks, Laurie. We'll hand back to Shani to introduce our final speaker. Thanks, Shani.
That was awesome to hear. Our next speaker is Jenny Pole. Jenny's been working within cancer services since 2013 after supporting her mother through ovarian cancer. She has found it rewarding supporting patients and their loved ones, working with a wide number of experienced nurses and colleagues. Over time, she found interest in stem cell transplant and was keen to explore and learn more. After a few taps on the shoulder with relieving in the role and increased hours with the health service available, she was able to work as a bone marrow transplant clinical nurse consultant since 2021. She is currently a member of ANZ TCT, and for those who aren't familiar with that, that's the Australian and New Zealand Transplant and Cellular Therapies Registry, and should be a member of a few more organisations. She really loves what she does, and like many colleagues, goes above and beyond to support as best as she can. So Jenny will be talking to us about stem cell transplantation. So take it away, Jenny. Thank you.
Thank you. I hope everyone can hear me. So it's nice to virtually meet everyone, and it's great to be able to speak to people directly who are keen to learn more about autologous stem cell transplants. And a special mention to Liam, who's going to be doing the slides. So next slide, please, Liam. So first-line therapy for myeloma involves induction treatment followed by consolidation treatment with an autologous stem cell transplant. And autologous means obtained from the same individual. So we're actually getting your own stem cells from the person. So research has shown an increased overall survival in patients with myeloma who had an autologous stem cell transplant in first-line treatment. So importantly, I guess my focus during this presentation is just transplant consolidation. It's quite a huge area. I usually spend about a good, sometimes up to an hour educating people. So I'll try and get through it as quickly as I can. Importantly, I'm sure a lot of people are familiar with the Myeloma Australia website. And so if people are considering a transplant, I would encourage you to definitely look at the Myeloma Australia autologous stem cell transplant booklet, a guide for people with myeloma. So there's a lot of really valuable information in that. Next slide, thank you. So my main focus is trying to briefly touch some of the following. So what are the advantages and disadvantages of an autologous stem cell transplant, proceeding to transplant, care and patient navigation, mobilising and harvesting stem cells, high-dose chemotherapy, reinfusion, common side effects and nursing care, and follow-up care. So the main advantages why we do transplants is that we want to consolidate the initial response from people's induction treatment. So I guess we want to put pause to the myeloma as long as possible. This is evidence-based. It does remain gold standard treatment. It is a safe procedure and it does improve people's quality of life and leaves behind a lot less residual myeloma cells. So the downside or the disadvantage of having a transplant is that people are going to get high-dose chemotherapy. This is a lot more toxic and it does increase side effects. There is a longer recovery, so it can be up to 3 to 4 months for a recovery. Not everyone will receive their desired response with a transplant. Fertility can be affected, and there is a risk of about 1 to 2% of death. So proceeding to transplant, these are the considerations that the treating haematologist that supports people through a transplant need to look at. So very much patient fitness, age and comorbidities. If you have an active lifestyle, if you have a sedentary lifestyle, are you independent with your own needs? Have you got issues with a physical or mental health disability? So there's lots of things that the transplant doctor does need to take into consideration. Another important thing is definitely having a dental review and assessment. Mouth care is really, really important. Some people may need to have repeat scans such as skeletal surveys and CT scans. There's quite numerous blood tests that occur, so people will need to have repeat protein markers and light chains. You might need to have 24-hour urine collections just to help monitor the response. Proceeding to stem cell collection, we need to go through specific viral marker testing as well. And sometimes the transplant consultant would like to have additional testing of either lung function test or a heart scan or maybe a kidney scan or something like that. So care and patient navigation. So in regard to specialist appointments, a lot of the transplants need to be done at quite a large hospital. And so it's very important for a transplant physician to be able to assess you properly. You actually need to see them face to face. Consent will occur at this time, and of course it's always important to try and bring a support person with you as well. In regard to stem cell collections, majority of these treatments are attended as an outpatient. In regard to proceeding to a transplant, a lot of people actually need to be admitted for their transplant, and as a guided mission, inpatient missions, probably for about 2.5 weeks. Some people with myeloma don't live right next door or don't live too far away from a tertiary hospital. So in each state, we do have patient travel assistance scheme. So there can be some people who actually need to travel quite a long distance to proceed onto stem cell mobilisation and transport and transplant. So support referrals include basically community-based organisations. So we have, of course, our Myeloma Nurses Australia. There is Cancer Council support, which is in each state and territory. There's the Leukemia Foundation, there's Rare Cancers Australia, there's the Arrow Foundation, there's Canteen that would be available to help if there's young people who have a grandparent or a parent that may be experiencing myeloma to help support them. There could be local charities relevant to your home state or district. There's a Look Good, Feel Better program. There is a new initiative called Carer Gateway, which is a service that does help provide support for carers. There's probably a few more that I can't recall, but there's definitely a lot of services out there to provide some support. Allied health referrals are usually in hospital referrals, but examples of these are social work, which I would encourage a lot of people to definitely be referred to. They can also assist with the patient travel. They're great at navigating issues with Centrelink, and particularly if people are needing to take time off work. There's the dietitian, there's physiotherapy, there's psychology. Some people are also referred to palliative care for support through pain management. And of course, there's Aboriginal health liaison officers, there's interpreter services. There's probably a few more that I can't recall either. Would always encourage everyone to have regular follow-up with their GP. GPs, of course, are getting a bit harder to get into, so your GPs will always continue to do your, sorry, that was my phone, to do your regular prescriptions and also pain relief. They can also do referrals to physio and psychology, particularly if your carer or loved one will actually need some additional help as well. A lot of people with myeloma do go on to prophylactic medication, and so the prophylactic medication is just to decrease your risk of getting any viruses or illnesses. And so two common medications that are used are valacyclovir, which is an antiviral medication, and Bactrim DS, which is an antibiotic which helps decrease the risk of having bacterial or fungal infections. So these two types of medication people will usually be on for quite a considerable period of time. Okay, so mobilising stem cells. So this is quite a planned and timed procedure. So it usually occurs after 3 to 4 cycles of induction treatment. It's very important to have good peripheral access for this. Sometimes people may need to have a central line inserted, which is either a permacath in the upper part of the chest, or might be a vascath on the side of the neck. There's two ways for mobilisation. So some transplant physicians will mobilise stem cells off cyclophosphamide and granulocyte colony stimulating factor, or GCSF injections. And then other transplant consultants may prefer just to use the GCSF injections and plerixafor. Our haematologists here usually use cyclophosphamide, and an example of how that is used is that we usually give cyclophosphamide on a Friday. So if we gave someone cyclophosphamide on Friday the 7th, the GCSF injections would start on Wednesday the 12th, and then we would actually start looking for stem cell mobilization on day 11, which happens to be today, which is Monday the 17th. In regard to GCSF mobilization, that usually those injections will you'll have them for 4 days, and then the centre will then start looking for stem cells at that time. So side effects from cyclophosphamide are low blood counts, increased infection risk, decreased appetite, nausea, might have some loose bowel motions, you can feel a little bit fatigued. People will lose their hair. And the GCSF injections, so there are a type of growth factor that basically help the bone marrow produce more stem cells. And we want an overproduction of these stem cells. So if you imagine a bucket, and that bucket is your bone marrow, we want that bucket overflowing. And that's what these injections do. They help just produce lots of extra bone marrow and the little stem cells. And those excess stem cells will go into your bloodstream. The side effects of the GCSF injections are bone pain, so people can get some additional back pain, hip pain, pelvis pain, sternal pain, headache, temperature, and also some nausea. Occasionally, some people can get an injection site reaction as well. Plerixafor is a medication that is sort of a bit like a backup medication, and that can enhance the amount of stem cells being moved from the bone marrow into the bloodstream. There are certain criteria for that to be able to be prescribed, and one of them that you do need to start to have some mobilisation or stem cell movement from the bone marrow into the bloodstream. If people are given this medication, most common side effects are diarrhea, dizziness, and headache. And for some people, they can actually get an upset tummy really, really quite quickly. Next slide, please. So apheresis and the stem cell collection process. So how do we know? So what we're actually looking for is that we need to do a CD34 target blood test. And the CD34 is a protein that's found on the surface of very early blood cells. So when people have a blood test, for example, this morning, the stem cell lab will be able to tell if mobilization has occurred. So how, once we have a certain number, we need a certain number to, I guess, to proceed for stem cell collection. People will have a cannula inserted in one arm, which is called the draw arm, and so blood will be removed. It will go through the apheresis machine. It mixes with an anticoagulant called citrate. There's a transducer at the bottom of the machine. There's a picture of the machine there on the slide, and that transducer spins really, really fast, like a washing machine. And there, the transducer splits and moves the stem cells up into a little bag, and then the rest of the blood product and the citrate is then infused back into a cannula in another arm. So this is a specialised procedure. You're nursed one-to-one. It will involve the whole day. It might be a multi-day procedure as well. It's very important that people wear comfortable clothes, bring your phone, bring your headphones, bring a support person, bring an iPad, basically just try and to make yourself as comfortable as possible. We do encourage people to bring their usual medications as well, particularly their blood pressure medication. There is a risk that having the apheresis procedure that it can lower your blood pressure a little bit. And for that reason, at our centre, we actually ask people not to have their morning blood pressure medications on stem cell collection day, but to bring them in with you. Some people may need to have specific heart monitoring that may not be able to be done at an outpatient unit where the stem cell collection process happens. And so sometimes people may need to be moved to a cardiac ward or a cardiac procedure room for the collection to occur. Briefly, citrate, I did mention citrate, so that is a blood thinner. When that does mix, and because we don't want any clots to occur during the collection process, so when the citrate mixes with your blood and is infused back into you, there is a risk of citrate toxicity. And what happens is that the citrate sort of draws the calcium from your bones. And so people can get some side effects, which is mouth tingling around your mouth. You might get a locked jaw. People might get some shin splints or some pins and needle sensations. And that is easily resolved by having a calcium infusion. So transplant specialists aim to try and get enough cells for 2 transplants. And so a minimum dose for a transplant is 2 million CD34 cells per kilo of body weight. And once we have enough stem cells for cryopreservation, they're cryopreserved and stored until we require them. So the time frame between stem cell collection and stem cell transplant can be a little bit dependent on, I guess, people's response from induction treatment. It can be also their transplant decision. Some people may need to have a little bit further induction treatment. Some people may need to do a lot more planning in regard to, particularly if they have to travel quite a considerable distance for their actual transplant. But as a guide, it's usually between 3 to 4 weeks from having stem cells collected to actually proceeding on to your transplant. So high-dose chemotherapy that people receive is melphalan. So briefly, the chemotherapy is given to attack and destroy cancer cells. The action occurs on rapidly dividing cancer cells as well as healthy cells. Our common rapidly dividing healthy cells are our bone marrow, our gastrointestinal tract, and our hair follicles. So high-dose chemotherapy in combination chemotherapy does increase the severity and the duration of side effects. So, for example, if you had your induction treatment, you collected your stem cells off cyclophosphamide, that's one more step up. And the melphalan chemotherapy is another step up in the, the severity of side effects. So importantly, the stem cell reinfusion aids in rescuing new damaged bone marrow from high-dose chemotherapy. If we don't have stem cells to reinfuse, people cannot proceed to an autologous stem cell transplant. Next slide, please. So this is an example of if someone at our centre was having a transplant as an outpatient. So melphalan is given on day -1. That's very important in regard to coordinating that we make sure it's not on public holidays or the weekend. Day 0 is the stem cell reinfusion. Patients will receive a phone call on day +1 and day +2. Day +3 and day +4, they'll present to our day unit. They'll have a blood test. They may require a blood product transfusion. They'll have a nurse review, a doctor review on our day unit, and then they'll go back to nearby accommodation, or if they live locally, they'll go back home. On day +5, it's the same as day +4, but the plan will be to admit to the hospital. They do start daily filgrastim injections again, or GCSF injections, and these injections are just one injection which help to aid engraftment, so help your stem cells that have been infused on day 0 to engraft back into your bone marrow. So as a guide, discharge follows engraftment recovery, which is around about day +14, which is 14 days post stem cell reinfusion. So to have our, go back a smidge. Thanks, Liam. So for outpatient treatment to occur, a support person is required with the person who's actually having the transplant. It's very important that our accommodation is actually close to the hospital. So with our centre, it's about 30 minutes. And if a support person is not available to stay with the person who's having the reinfusion, then the patient will need actually to be admitted for the whole process. Next slide. Thank you. So day -1 is the conditioning chemotherapy. If not already, people do need to have sessional venous access for the melphalan chemotherapy. This can either be a Hickman line, which is in the upper part of the chest, or it can be a PICC line, which at our centre it's inserted via our vascular access nursing team. The conditioning therapy is given a day prior to the stem cell reinfusion. Do allow about 3 to 4 hours for the treatment on the day unit. A little bit longer if you're having a PICC line inserted on the same day. People get pre-medication hydration. And importantly, just prior to starting melphalan, people will get ice chips. And so it's important, the reason why people get ice chips is to decrease the severity of mouth sores and mucositis. So it's important when having the ice, you just have an ice cube, allow it to melt slowly in your mouth, and then get another ice chip. Some centres will do icy poles, and if you're lucky, you might get ice cream as well. Next slide. Transplant day, reinfusion day is day 0. So this will occur, infusion of the stem cells occurs 24 hours after the melphalan chemotherapy. So for example, if you were having melphalan today and the melphalan finished at 1 p.m, we wouldn't be able to reinfuse your stem cells until after 1 p.m. tomorrow. People do get pre-medications and fluid hydration. Occasionally, prior to reinfusion, the stem cell scientists will actually wash the cells, and what they are doing is actually removing the dimethyl sulfoxide or the DMSO cryopreservation agent. And if your people are allergic to sulfur, or they may have some amyloidosis, that just decrease any risk of a possible reaction. So the infusion times vary depending on the number of stem cell bags required, and so that's dependent on how many bags the 2 million or so stem cells are spread into. The infusion, the actual infusion itself is about 5 to 10 minutes. At our centre, if you have a Hickman line, we prefer, nurses, as nurses, we prefer a Hickman line because it's a bigger line. If people have a PICC line in, we actually also insert intravenous cannula to infuse our stem cells. As mentioned, stem cells just go over about 5 or 10 minutes. The picture on the screen there is really good. That's basically an example of the colour of what stem cells actually look like. Some other centres will infuse the stem cells through a PICC line, and they actually might use a syringe to infuse the stem cells with. We just happen to don't do that at our centre. So immediate possible side effects are breathlessness, decrease in blood pressure, fever and shivering, flushing, nausea and vomiting, and extreme but rare cases, the patient could lose consciousness. Common side effects of the DMO preservative is a flushed face. They can feel a little bit cold. People can get a tickle in the back of the throat. They can have an unusual taste or smell. What's fairly common is the smell that the patient will have following their stem cell reinfusion. They usually can't smell it, but everyone else in the room and their loved one or their support person will actually smell it. Some people describe it as it smells like tinned cream corn. Some people have mentioned tinned tomato soup. We have one nurse here that thinks it smells like Ribena. I can tell you it does not smell like Ribena. This smell usually lasts for about 24 hours. And the reason why is that the patient who's received their stem cells, the DMSO comes out through the pores in their skin, and they also breathe it out as well. We do encourage to bring lollies in just to try and decrease the risk of the tickle in the throat. And the most common things that I've seen is a slight decrease in blood pressure, a little bit of a tickle in the throat, and of course the unusual smell. With reinfusion process, we do ensure that we have a doctor on the unit. They don't need to be in the same room as the patient, but we just ensure that for safety reasons that we do have a doctor on the unit. Next slide, please. So the common side effects of the conditioning chemotherapy are mucositis, infection, nausea and vomiting, diarrhea, decreased appetite, pain, fatigue, changes in memory and concentration, and hair loss. It is very important, of course, if you patients are an inpatient or even an outpatient, you do start to experience symptoms, do let someone know. If you have had medications for, whether it might be for pain or for nausea, and they haven't been effective, do also let someone know, because there's always something that could be given that's a little bit stronger. Next slide, please. So oral mucositis, of course, is something that is very, very common with chemotherapy. So this involves swelling and inflammation of the lining of the mouth. And this swelling and inflammation does go through the whole digestive system. You can get colour changes inside the mouth. You can get pain while you swallow, while you talk. You can get mouth ulcers. You can also get bleeding from these ulcers. Saliva can be quite thick, or it can actually be non-existent. So treatment is oral hygiene, particularly regular sodium bicarbonate mouthwashes, and also the good old-fashioned salt gargle. Some people may need to have antifungal lozenges or nystatin liquid to help if there's a fungal infection. There's Kenlog gel, which can help with some pain for ulcers, regular pain relief. In extreme cases, some people may need to have a syringe driver that delivers an effective amount of pain relief over a 24-hour period. Good denture care is important. Xylocaine viscous and Mylanta, also noticed that pink lady is also quite common, given regularly before meals. Regular lip balm. In extreme cases, some people may need assistance with total parenteral nutrition, which is TPN, or either nasogastric feeding as well. They're not very common, but it is very important as a part of the education process that people are aware that that could occur. Next slide. So infection and pancytopenia. So infection, we definitely, there is a huge risk, particularly in neutropenia infection. So like anything, a thorough septic workup would occur. People would go into antibiotics, there'd be blood cultures, there'd be scans. People may need to have additional fluids and electrolytes. Of course, temperatures usually occur on the weekend or very early in the morning. So the staff may initiate a MET call to get some more support available. If you're an outpatient and it's very early on and it's only day +3 or day +4, this is where having a support person does come into factor. If you notice that you do have a temperature, the expectation is that we would get you to present to the emergency department. Blood product replacement, platelet transfusion is quite common. Some people, not many people, but some people can actually go through a transplant and not actually require a blood product replacement or platelet transfusion. It's not very rare though, but it is very rare, but I've come across a few patients that's happened to. As previously mentioned, GCSF injections do start on day +5. Need to definitely consider the patient environment, a single room, be mindful of visitors. Very important to have good hand hygiene. And in some centres, even having flowers in the room is not appropriate. So the lovely little squiggly lines that I've added to this slide is basically a patient who has recently had an autologous stem cell transplant for myeloma. What I wanted to very much bring to everyone's attention is that they had their conditioning treatment on the 20th of February, their reinfusion on the 21st of February. The green line is the person's neutrophil count. And so at day, on the 26th, which is day +5, you can see that the neutrophil count is a little bit less than 2. And so from day +6 to approximately day +10, that day +11, they were actually neutropenic. So that is, of course, quite common. And what is important is that around that time when people are in hospital, that's when the severity of the symptoms are usually at the worst, that is heightened. And patients have described to me is that when they do get their symptoms, they tend to come in waves. And so sometimes the waves come quite quickly, and then gradually the waves definitely start to come back quite slowly. Next slide, please. So nausea and vomiting, regular dose anti-nausea medication is quite important, and sometimes there's always stronger anti-nausea medication that patients can request. Severe cases, they can have a syringe driver. There is a risk of having dehydration, so fluid and electrolyte replacement is quite important. When patients are an inpatient, they are in our hospital, they're automatically seen by the dietitian. So very much encourage regular small meals, definitely eat slowly, encourage people to sit out of bed for their meals, and not to definitely don't lie down while you're eating. Some people benefit from having peppermint or ginger tea. Diarrhea is a very common side effect. So probably about 80% of people will get diarrhea. It usually occurs from 24 to 96 hours after having the melphalan chemotherapy. One of the first things that we do is we'll send off a specimen to make sure people don't have a bug. If people do have a bug, you'll get some antibiotics to treat that bug. If you don't have a bug, we can give you some medications such as gastrostop or codeine phosphate just to try and decrease the severity of your bowel motion. So the dietitian's very handy here in the way that you can get onto a special protein diet. So it's just so you can avoid the fatty, creamy and sugary foods. Be mindful of stringy vegetables. I always encourage people to avoid coffee. Coffee can be quite hard on the digestive system, and it actually can make people definitely feel a little bit more queasy. Next slide, please. So fatigue, unfortunately, there's no magic cure for fatigue. Patients feel physically and mentally drained. They have low energy and motivation. People can find it difficult to concentrate. They can have trouble sleeping at night. Some people can actually start to feel a little bit depressed. Very important to pace yourself. Definitely plan ahead. Do break down tasks into manageable goals. Some people find it beneficial to keep a diary. I do have goals and some things to definitely look forward to, and definitely consider physical activity and exercise. Some people can get some memory loss and forgetfulness and also feel a little bit vague. Definitely we provide a lot of reassurance with that. And I guess having a calendar, diary, support person is very handy. And in severe cases, some people might need to be referred to a clinical psychologist or an occupational therapist. So I just wanted very briefly to touch on engraftment syndrome. I have seen this recently, which is why I've added it in. This usually does occur following an autologous stem cell transplant. It's characterised by non-infectious fever, weight gain, hepatic and renal dysfunction, skin rash and pulmonary edema. The exact cause is not fully understood, but it's thought to be related to the release of inflammatory cytokines. So it usually occurs just prior or post engraftment. So it's anywhere from about, say, day +9 up to maybe a week, so that day +16, day +17. So there is a slight risk this can occur when a patient has actually gone home. So most cases are really, really mild. It's more common in females, younger females, people who've had minimal chemotherapy, and particularly myeloma patients. If it does occur on a ward, we do the full septic screen workup. They have antibiotics, and if they need to, they'll end up having steroids. So I guess the take-home message is that if people are discharged, it's still very important to definitely keep an eye on your infection risk. And if people do have a temperature, it's very important to present to the emergency department. Next slide, please. So follow-up, as previously mentioned, as a guide, if you're inpatient, it's usually about 2 to 2.5 weeks. At our centre, we do a phone call follow-up, usually within the first week, and depending on how that conversation goes, we end up doing a few more follow-ups. Or if the person actually feels quite good and independent, we actually stop our conversation there, but we usually end up catching up with people quite regularly in the clinics. It is important to have a specialist review 2 to 4 weeks post-discharge. Sometimes in some places that can be a little bit longer. Definitely make an appointment just to say hi to your GP, just to check in to make sure everything's going okay. Maintenance treatment can be commenced, and usually that starts about 2 to 3 months after a transplant, because we want people to recover from their transplant. People are eligible to have their vaccinations as per the immunisation schedule, and these start from about 6 months following a transplant. Depending on where you live, some may be incorporated within the health service, and some, unfortunately, you may have out of pocket expense for that. Very important also to continue having regular flu jabs and be revaccinated against COVID. We can't make people be revaccinated, but if it's something that you are considering, I would definitely encourage to have hepatitis B and the respiratory revaccinations. Just another little plug here for the support groups and services. There's some people that, although we educate, just go back a smidge. Sorry, Liam. Some people who we actually support haven't actually felt comfortable to be referred to support groups. So sometimes it is a time where some people actually do definitely do that. In regard to returning to work, very much I try and encourage people to have at least recover for about 4 to 6 weeks. Some people do need to have the stress of actually needing to return to work for financial reasons. And if people do need to return to work, it's very much to engage in a safe return to practice and actually start off quite slowly. And just to finish up, definitely fatigue management. Everyone manages fatigue differently. Physiotherapy and exercise, I know that there was a discussion prior to that, that's really important to definitely focus on. And at the end of the day, I don't have the answers for fatigue, but gradually people will realise that they'll find out that they might be better in the morning compared to the afternoon. And so in regard to thinking about returning to work, people may realise, they might have to do work in the morning. Usually around the 6-week mark after transplant, most people start to feel that little bit better and that little bit stronger. But at the end of the day, it is an individual process. And I think that's it. There's some references there. Definitely check out the myeloma website if you haven't already. EVQ is Cancer Treatments Online, is where there is a lot of protocols. I think the next slide's the reference list, which you don't need to worry about that. And then the last slide's some 90s version of stem cell collection, the chemotherapy and the actual transplant. So that's it. I'm very sorry I've probably spoken too much, but there is a lot of information to try and get in.
Thanks very much, Jenny. That was very comprehensive. In fact,
I'm so sorry.
We don't have time for questions, but as mentioned previously, if anyone does have any questions, please feel free to email us, and if we can answer them, we'll certainly help. Otherwise, we'll forward them on to whichever speaker they're directed at. So that concludes our seminar for today. We hope you found the sessions informative. Please don't forget to send through questions, as I've just mentioned, to our nurses' email, which is nurses@myeloma.org.au, or call through to our telephone support line on 1800 693 566. And we can either book you in for a phone call, if someone's available, we can have a chat. We also really want to hear your feedback. So if you scroll down, there's a section there for feedback. Please complete the survey, because we really value it and it helps build our programs for subsequent years. So yeah, the link is at the video at the bottom. And finally, mark your calendars to join us for our second seminar, which is on Thursday, the 20th of March at 12 p.m. Australian Eastern Daylight Time, which is 9 a.m. for those of you on my side of the country. Before we sign off, I would also just like to really give a heartfelt thanks to all of our presenters today. Everyone's insights and information was wonderful, and I'm sure you guys got a lot out of it, and I know I certainly did. I was madly making notes myself. Thank you to the organising team at Myeloma Australia for pulling this together. I feel a bit lucky because I was just pulled in last minute to MC, so thank you. It's been a wonderful program. And these sorts of things can't happen without our sponsors, so I'd really like to do a shout out to Pfizer and Johnson & Johnson for helping make this happen. And last but certainly not least, a massive thank you to Liam and Darren and the whole team at CVP for their skillful production and making sure today's event went as planned. I hope you all have a wonderful day from wherever you're watching, and please, if you have questions, email us or call us. Our goal is to help you guys and support you guys, so if we can help with questions, we'd really love to help you. Thanks, guys.